I think that means we're live on all of the platforms. Outstanding. As we would do if we were live in a conference room, we'll give people a few minutes to sort of make their way in. Not everyone is as prompt as you early overachieving early arrivers. So for questions, we'll be doing them by typing comments. And so feel free, you can even start now if you'd like to start asking questions. If you'll go ahead and start sending those, then my producer's going to feed those to me. And but the more the better. And so if you want to go ahead, if you have questions that you know you want me to ask, go ahead and start doing those now. That'd be great. Again, if you're just clicking in, we're happy to have you. This is the Endometriosis Live Q&A. I'm Dr. Chris Stroud. It's great to have you with us. And if you have questions and comments that you'd like me to address, just go ahead and start sending those in, typing those in, and I'll get those. I think we're getting a couple already. That's great. Appreciate you coming out on a Tuesday evening and spending a little bit of time talking about one of my favorite topics. Maybe not yours, but it might be yours, or you wouldn't be spending a Tuesday night live with me. So, you know, while people are joining us, just by way of sort of an introduction, let me start. Again, I'm Chris Stroud. I'm an OBGYN of really almost 33 years. Endometriosis and I have a pretty unhealthy relationship, some would say. I spend most of my waking hours doing something either directly or indirectly related to endometriosis. At least it seems that way many, many days. And so if you're here, you must have seen something that I posted about endometriosis, and you have questions about this really pretty horrific disease that affects millions of women. Literally 1 in 10 women are afflicted with endometriosis. So this is not an uncommon phenomenon. One of the many frustrating characteristics of endometriosis, I guess I would say, is that it often goes undiagnosed or misdiagnosed, sometimes for decades. So the diagnosis of this disease is one of the biggest challenges that we face. Just getting physicians to suspect it and then to look for it properly can be one of the biggest challenges. So I hope that we can unwrap a lot of that by answering your questions as they come. I've got some video footage that I want to show you of real surgeries so we can get a real sense of what the anatomy looks like and what we're talking about when we're talking about endometriosis diagnosis and surgery. But if Andrea is my producer, and Andrea, if you want to give me a question as they come in, I'll go ahead and start working on those.
Sure. We've got questions so far, like I got pregnant before my endo surgery. Should I still have the surgery after I give birth?
That's a good question. I'll start with that one. I got pregnant before my endometriosis surgery, and so canceled the surgery. Now have had the child, hopefully, or soon to be. And should I have the surgery anyway? I'm going to back up for a minute, just by way of a little bit of a disclaimer. While I am a physician, let's be clear, I'm not your physician, unless I am your physician. And if I am, thanks for joining. If I'm not your physician, for any of the would-be lawyers there, let's be clear, I'm giving opinion and I'm coaching. I'm not giving medical advice. So I just want to be clear about that so that everybody stays out of trouble. So this actually comes up a fair amount in that we diagnose, we make a plan, and because we're not in charge, the patient becomes pregnant, which is wonderful. Then what do we do after that? I usually recommend we do nothing after that, at least not right away. If the couple wants to be pregnant again right away, typically I would advise begin pursuing pregnancy. But then if it doesn't happen quickly, within maybe 3 or 4 good cycles, then we should rethink our plan and maybe go back to the surgery diagnosis option. If pain was a big part of the presentation of the endometriosis, and that led to our decision to go to surgery, then we could use the absence of the presence of pain as something to drive our decision to go back to surgery. But after pregnancy, there may be a long interval where the woman is pain-free even after her menses restart. So there's not a one answer that fits all there. I would say, generally speaking, we play it by ear. Great question, though.
Another question, is endometriosis genetic?
Is endometriosis genetic? Yeah, that's a phenomenal idea. And today on the test, if you were taking the test today, you'd have to say no to get the right answer. But I think no means not yet. That's just my personal opinion. I certainly see so many mother, daughter, sister, cousin combinations. And when you start asking questions, everyone in the woman's family has had similar symptoms, and maybe they weren't diagnosed, but it sure sounds suspicious for endometriosis. So we don't know. The answer today is no, but I'm not sure it'll always be that answer. The other thing is, I think at some point in time, now this is just my opinion, I think it's shared by others as well, maybe long after I've moved on, we'll be talking about endometriosis more as an autoimmune condition than necessarily the way that we talk about it today. We'll see about that, but that's just an idea.
This question, sort of related to that last one, can pregnancy improve symptoms? She says, I've had an ablation, but still having problems. Don't know whether to get an excision again or try to get pregnant.
Yeah, can pregnancy improve symptoms? I don't know what to do, essentially. Great question there, too. There's a bit of mythology, and I'll admit I found myself repeating it from time to time, that pregnancy has magical effects on endometriosis. It certainly appears to sometimes. There are times when it doesn't appear to have an effect at all. But there is sort of a conventional wisdom, you might say, that if you have endometriosis and you become pregnant, it will postpone the recurrence of the disease. There's really not any good proof that that's the case. It may or may not happen. So much like I mentioned in the first question, should I now go have endometriosis surgery after pregnancy? I would say the same is true, in this case. I would base it on the symptoms. Is pregnancy occurring when it should? Is pain occurring? And that would drive us, to go back and do that again. But there's really no guarantee that pregnancy is going to have an impact at all on the endometriosis. I can think of an example. It's not a common example, but this happened to me where I did a big endometriosis surgery. Then about 4, maybe 5 months later, the woman became pregnant, but it was an ectopic pregnancy, a pregnancy in the tube. So I had to go in with the laparoscope to do the surgery on the ectopic pregnancy. And as I looked around, it looked as though I had never been there. All of her endometriosis had come back with a vengeance in only about 6 months. Now, I don't think by any means that's common, but it's also not impossible. So I think the reality is we don't know if pregnancy has an effect, or maybe it doesn't have a predictable effect on this crazy disease.
We have a couple of questions. This question's coming up a lot. People are asking, I have endo, it's been diagnosed. People are telling me IVF's the only option.
Oh, yes. No. let me think of the best way to answer that. No, and maybe no on top of that. So that's just not the case at all. Every day in our practice, we see women with long-standing infertility, and they often haven't even been evaluated for endometriosis. So the people asking these questions, if they know they have it, they're even in a better place than most women are, because often the pelvis is not evaluated as part of the infertility evaluation. We're always asking 3 categories of questions from an infertility perspective. Category 1, is there a sperm? Category 2, is there an egg? And category 3, can those 2 parties get together? Well, it's that third category that's endometriosis. And so most of the time, sadly, the third category is never even evaluated by the physician. So if you've been evaluated and you're known to have endometriosis, it should be removed or excised. Now, in a minute, I'm going to show you some video to show exactly what that looks like and what that means. Not burned, not scraped, not ablated. It has not coagulated, not full graded. Those are all words that really mean something other than cut out. But if the endometriosis is completely excised everywhere that it exists in the pelvis, no matter what it's on or what it's touching or what it's near, then that gives you your absolute best chance at natural pregnancy. And there's some really good research on that by a researcher named Dr. Young He's currently in St. Louis. You can look him up, but he's got probably the most published data out there that shows pregnancy rates tremendously improve after complete excision of all of the endometriosis. So IVF it never has to be the option, the answer for endometriosis-based infertility or for really any other kind of infertility. And then I'd go further to say there's now emerging research that's beginning to suggest that IVF success rates go up if we remove the endometriosis from the pelvis. So occasionally now, I'll get a referral from an IVF doc that says, I know we're on opposite sides of this, but I think she has endometriosis. Would you look? And if she has it, would you cut it out? Because I think it'll improve her IVF success rate. So for so many different reasons, the answer to that question is no, no, and no.
We had someone follow up with that to ask if low AMH has any impact on whether there's hope with the excision treatment or if IVF's the only option.
Yeah, AMH. We could do a podcast, maybe I have or I should, just on AMH. That stands for anti-Mullerian hormone. It's a lab test that's done, and it's often described as a measure of ovarian reserve, sort of a way to say how much gas is left in the tank, you might say. And the interesting thing about AMH is it goes down with age, and as a woman approaches menopause, the number gets smaller and smaller. Presumably, it's at its greatest in adolescence, and then it begins to decline, much like our natural fertility does. But anyone who has an AMH blood drawn done, on the written report, somewhere on that report, there's usually a disclaimer that says something along the lines of, this is not FDA approved to predict pregnancy. And in fact, it has never been FDA approved to predict pregnancy. It is only proven beneficial for one thing, and that is predicting who will respond well to IVF drugs. Not who will get pregnant with IVF, not who will get pregnant naturally, but whose ovaries will respond in a positive way to the IVF drugs. So the IVF practices often use that really as a gatekeeping screening tool. So if you were, say, in your mid-40s and you go to your local IVF provider, they're going to draw an AMH. And if that number is low, they're going to say, we can't stimulate you, you need donor eggs. Now, in fairness to them, they're saying that because they don't want an unsuccessful stimulation. They have to report every cycle of stimulation to a public database at the CDC, and that's publicly available to the consumers, to you. So anything they can do to keep their success numbers high, I understand, that's what they're going to do. So they use the AMH as a tool to do that. I personally have delivered many, many children for moms with low AMH. It can't be used to predict who is going to become pregnant, whether they have endometriosis or not. It simply isn't designed for that, and the research has never proven that it's beneficial for that. As far as endometriosis goes, that wouldn't change the answer. No connection between whether you'll become pregnant with endometriosis and your AMH is this level or that level. Not at all. Great question.
We got a couple of questions that I suspect are related. We've got one about, do you recommend hormonal treatment after excision? And then a sort of related question, I think, is there anything you can do to help prevent endo from coming back after an excision?
Yeah, let me go in reverse order. So what can you do to prevent recurrence? The short answer is we don't know. Complete excision, I think the research overwhelmingly supports, is by far the most important thing. Complete excision, not partial excision. I got most of it. I think I got most of it. No, that's not complete excision. Think of it as a cancer. It has to be completely excised. That gives you your best chance at it not coming back. After that, we have some ideas, but there's not a lot of research that can, definitively say. Certainly eating what's sometimes called the anti-inflammatory diet, or sometimes called the endometriosis diet, which is really gluten-free, dairy-free, inflammatory oil-free, and a few other things free. Pretty much anything you like, you don't eat it. And that'll increase the chance, maybe, that your endometriosis doesn't come back. Certainly anecdotally, I see women every day that will say their pain is improved if they eat and live in an anti-inflammatory way. We're just lacking the research to prove that the disease is managed by that. But certainly, it's a bit of an extrapolation, but we certainly see improvement in symptoms for women who live and eat in an anti-inflammatory way. The other really important medication that we like to use is called naltrexone, Naltrexone. And more specifically, if you want to research this, it's low-dose naltrexone, sometimes just called LDN. And if you want to Google that, you want to Google LDN for endometriosis, because LDN has become the rage in all things inflammatory, whether that's inflammatory bowel disease or fibromyalgia, anything that has to do with autoimmune dysfunction or inflammation, someone is using LDN to treat that. We use it a lot in cases where we think there's an autoimmune component to recurrent miscarriage, for example. But certainly it appears to have a role in the treatment of recurrent endometriosis. Don't get confused when you look up naltrexone. Its fundamental purpose is for treating heroin addiction. So if I recommend you have it, it doesn't mean I think you're a heroin addict, right? At high doses, the kind that you can buy from a commercial pharmacy, it blocks the opiate receptors. So if a recovering heroin addict were to use the drug, if they're taking their naltrexone, they'll get no effect. So that doesn't make their brain want to seek that drug. But at lower doses, it seems to have magical properties on the immune pathways and some of the inflammatory pathways. So you have to get it from a compounding pharmacy. We usually start at 2.5 milligrams and titrate that up to somewhere around 5 milligrams, sometimes a little more depending on the specific circumstances. But it's become a really important tool in treating recurrence. The other medication, or the other question, the first one was hormone therapy. And I think maybe what the viewer meant to say was really anti-hormone therapy, you might say. I'm not sure. But stealing estrogen away are anti-hormone therapy. So estrogen is to endometriosis what water is to plants. If you take the estrogen away, the endometriosis essentially dies and withers away. Now, not dissimilar to weeds, when you return the water, the weeds return, and so does the endometriosis when the estrogen comes back. But anti-estrogen therapy, in the form of what's called GnRH agonist, the most common of which, the oldest of which is a medication called Lupron, they actually turn the ovary off temporarily and thereby turn off estrogen, and in the absence of estrogen, endometriosis withers away. It is not a cure. It can be a treatment. I tend to think of it as a bridge treatment, maybe to something else. But there are cases where, with really extensive endometriosis, and maybe we've just been unable to remove all of the disease, maybe because of extensive bowel involvement or some unique surgical circumstances, sometimes we'll recommend maybe 6 to 12 months of an anti-estrogen therapy like Lupron, almost like you would recommend chemotherapy after a cancer surgery. That's not common, but it is a tool that's sometimes in our bag. Let me, while we're on that topic, say something about birth control pills and endometriosis. I'm guessing someone was going to ask me this, so I'll just cut to that topic right away. The cure for endometriosis, as I've said, is the absence of estrogen. That's also called menopause, right? In menopause, with a few rare exceptions, all of the symptoms and the problems of endometriosis go away. So the cure is the absence of estrogen. Now, I don't mean that estrogen causes endometriosis, right? Water doesn't cause the weeds, but it does feed the weeds. So estrogen does feed the endometriosis. So the absence of it kills the disease, so to speak. What's in a birth control pill, you might ask yourself? Estrogen is the predominant thing in a birth control pill, and in addition to a synthetic version of progesterone called progestin. But in what universe does it make sense that if the absence of something is estrogen, to treat it, I'm going to give you estrogen? And I hope you're saying to yourself, that makes no sense at all, because it doesn't. Yet it's the most common thing given for endometriosis. And sadly, it's a terrible mistake. It does treat the pain, and sometimes it treats the pain very effectively, which is really part of the problem. I think the most common scenario that I see is maybe a young woman, maybe in middle school or high school. She's having horrible pain. Her mother takes her to her mother's gynecologist. They say, oh, you probably have endometriosis. Let's put you on the pill. After a month on the pill, the young woman is feeling better. She's happy. Her mother's happy. The doctor's happy. Everybody's happy. Yet the research is very clear, the disease marches on. So then I meet her maybe 10 years later. She's stopped the pill. She wants to be pregnant. She's not getting pregnant. Oh, and by the way, I feel like I'm 14 again and my pain is back. So it has really no role in the effective treatment of endometriosis. And so it's a commonly done thing and it's a commonly done mistake. So stay away from birth control pills for the presumed treatment of endometriosis.
So another question I've gotten multiple times now.
Uh-oh.
What about hysterectomies for treating endometriosis? If you're done having children, you know you're not having any more children.
Yeah.
Is it effective?
It's an important topic, and it's a little bit of a catch-22 answer. I recently saw a nice description of this on the Endometriosis Foundation's website. Their site is Endo, ENDOFOND, I believe. But if you just Google Endometriosis Foundation, terrific organization, raises a lot of money for research in endometriosis, not nearly enough, unfortunately. But they, in one of the myths, they point out that hysterectomy isn't necessarily curative for endometriosis. And that is true unless all of the endometriosis is also excised. So if we remove the uterus and we excise any and all of the endometriosis, with a few glaring exceptions, that is curative. Now, in that scenario, I'm suggesting that we leave the ovaries behind. And that's really the defining component to the decision. So if we leave the ovaries, take out the uterus, take out all of the disease, depending on the study that you quote, there's somewhere in the neighborhood of 3 to maybe 8% chance that the disease will come back even though the uterus is gone. If that should happen, we can go back, we can remove the ovaries, remove the disease, and that's curative. So you might say, well, why don't you just always remove the ovaries when you take the uterus out and when you take the endometriosis out? We might be talking about a woman in her 20s or in her early 30s who's given up and said, I can't live with this, I want a cure. But if I take her ovaries at that young age, she might have 20 or 30 years that she's got to take exogenous or extra estrogen medication. So we might decide to sort of play the numbers and say, look, there's a 90, 92% chance that it won't come back. So why don't we do that because you're so young? So that's part of an important back and forth discussion that really needs to happen with your surgeon before you decide how to proceed. But really, for the sake of our discussion, properly done hysterectomy, removing all the disease and removing the uterus, plus or minus the ovaries, can be thought of as curative for the overwhelming majority of women. I tend to think there's sort of two common final pathways for endometriosis. One of them is menopause, and one of them is a hysterectomy. And on both of those, I just pray that they've had children along the way. Now, sadly, that's not always the story. But those are really kind of the two final common pathways for this devastating disease.
So let's switch from all these treatment questions to some diagnosis questions. Julie asks, what are some trigger symptoms that could be alarming for periods or ovulation, could be an indicator of endo?
Yeah, an important question, absolutely. Especially, I get that question a lot from moms with daughters, and they're worried about their young daughters. And so one of the tricky things is about 50% of women with endometriosis have the classic symptoms, and they are all sorts of pain. So pain with menses usually precedes the period and then gets worse with the period and then begins to resolve as the period resolves. Pain with menses, we call that dysmenorrhea. Mid-cycle pain, pain around the time of ovulation. Pain outside of either of those, just chronic pain in the pelvis. Painful bowel movements around the time of menses. Those are really common classic symptoms of endometriosis. Intense bloating. Sometimes on social media, you'll see people maybe demonstrating with pictures of their own body what's called sometimes endo belly, with intense bloating during the cycle, followed by a flat abdomen, followed by a protuberant abdomen from all of the bloating. Chronic constipation, diarrhea, so-called digestive problems. Many, many times women are told they have irritable bowel syndrome, when in reality they have endometriosis causing horrific inflammation, causing their irritable bowel syndrome. But those are really the classic symptoms. So pain, and more pain. The problem with that is only 50% of women with endometriosis have those symptoms. The other 50% of women have what some people call silent endometriosis. In reality, it's not silent at all. Their symptom is the absence of pregnancy when everything else is normal. Remember I said there were those three categories of questions. So if there is a sperm and if there is an egg, the woman is ovulating and she's not conceiving, in all likelihood, endometriosis is the cause, even if she doesn't have pain. So if she's in the 50% of women that don't have pain, that's her symptom, the absence of pregnancy. So if pain is there and we're talking about fertility, I'm really suspicious. But if pain is absent, I'm still suspicious that she could have endometriosis because only 50% of those women have pain.
Another diagnosis question. If someone suspects they have endometriosis, should they consider having the exploratory surgery to diagnose right away, or should they wait until they're ready to get pregnant? She says pain is a factor, painful periods, pain during intimacy, pain in their hips, but their current gynecologist just keeps trying birth control pills.
Yeah, we'll try. We won't try. We'll show some video here in just a minute of what it looks like at laparoscopy when we do a diagnostic laparoscopy. I try not to use that phrase, exploratory surgery. Now, I know I'm being a little word policey there, but it just conjures up, I think, the wrong image. You know, the procedure is called a diagnostic laparoscopy. It takes me about 20, maybe 25 minutes to perform that procedure properly. It involves a quick general anesthetic, a small nickel-sized incision somewhere in or around the belly button. I put a 5mm camera in that's about the size of a writing pen. And we do what I like to think of as a CSI investigation of the pelvis. There's nowhere that I don't look. By the gallbladder, by the spleen, around the diaphragm, behind the colon, everywhere in the pelvis, looking for that disease. If it's there, we map it out. I usually video that. Then we sit down a couple of days later, go over that video, and talk about our findings and what we could do. But it is no more complicated than maybe a straightforward diagnostic colonoscopy. In some ways, for the patient, it's a lot easier than a colonoscopy. So I just take issue sometimes when I hear people say exploratory surgery. The old surgeon in me thinks that means I'm going to open somebody up stem to stern and look inside. Thank goodness with technology the way it is, we don't have to do that. But it really is a minimally invasive procedure. But that's the only reliable diagnosis. And in my opinion, if you're thinking about endometriosis, you should have already looked. I've looked in 12-year-old girls and found it. Because if I can find it early on, I can do something about it then, so that it's not going to be life-disrupting for her. And equally, and maybe more importantly, it's not going to potentially permanently damage her tubes. Not uncommonly, I have to sit down with a young woman and her husband who've been trying for the 2 years they've been married, only to tell them, your fallopian tubes are destroyed, and there's nothing that we have to offer, really, that's going to offer you a chance at natural pregnancy. And I can tell by the look on her face, she's thinking, I should have done this sooner. I should have done this maybe when I was in high school. So if there's pain, if there's a problem like that, don't throw birth control pills at it. It'll just cover up the pain. See somebody who's willing to do the appropriate diagnostic procedure. It is not complicated, and it'll get you a definitive answer.
This person wants to know, Jessica wants to know, can hormone manipulation, like with things like letrozole, Clomid, increase the risk for endometriosis or return of endometriosis?
Yeah, it sort of gets back to my water plant analogy. So things like letrozole or Clomid, we use to raise a woman's FSH, follicle stimulating hormone, to make her stimulate a follicle because we're trying to get her to ovulate for pregnancy. Well, a follicle produces estrogen. That's part of its job. It makes the lining of the uterus grow. So that's a natural part of the fertility cycle. FSH causes follicular development. A follicle developing causes an increase in estrogen. But to increase one's estrogen is not to cause endometriosis or to cause its return if it's been treated. Now, taking it away will treat the disease, but its present doesn't cause it. That's the causation-correlation phenomenon. Hope that makes sense.
this person wants to know, is it possible to have PCOS and endo?
Oh my goodness. It's not only possible, it's probable. The question, if you didn't hear, is it possible to have PCOS and endometriosis? Some really good research will show anywhere from 50 to 70% of women who have polycystic ovarian syndrome also have underlying endometriosis. And remember my other 50%. 50% of women with endometriosis have pain. So if a woman has polycystic ovarian syndrome, whether she has pain or not, I can flip a coin and be right more times than not that she also has underlying endometriosis. So if I know you have PCOS, I'm already thinking we should do a diagnostic laparoscopy to see if you're in the 50 to 70% because we need to find that out now, not later. So that's an incredibly important question, and that correlation between polycystic ovarian syndrome and endometriosis it's just huge. We don't understand why there would be such a strong link, but that link is there. We can't ignore it.
Can you talk a little bit about the stages of endometriosis and when surgery is and sort of becomes the appropriate treatment, and how much it can impact not just I'm feeling better, but am I going to be able to get pregnant?
Yeah, so the staging is an important topic. So unlike staging with cancer, endometriosis staging doesn't predict behavior. So if someone says you have stage 4 breast cancer, you can predict the next 12 months of that woman's life and be relatively correct because cancer tends to behave in a relatively predictable way in that regard based on stage. That's absolutely not true with endometriosis. It's one of the many frustrating things with endometriosis is it doesn't follow its own rules, much like I alluded to earlier with the example of the ectopic pregnancy that I gave. So staging is important in research communities and in research discussions to make sure that we're comparing women with similar disease, if we're comparing treatments and then looking at their outcomes. But it is not important in how we manage the disease, and that's why it's important not to pay too much attention to staging. But there's 4 stages, and the more endometriosis you have, whether it's limited to the pelvis or outside the pelvis, whether there's adhesions or not, whether it's in the ovaries in the form of endometriomas, the higher the staging, the more advanced the disease, the more likely stage 4 versus stage 1, which would be very limited disease. Now again, the problem with staging is any endometriosis is a lot of endometriosis. Again, imagine a cancer doctor telling you, don't worry, you just got a little bit of cancer. You wouldn't accept that as an answer. Any endometriosis is a lot of endometriosis, and any endometriosis should be removed in terms of protecting fertility for the future, even if the person doesn't want to be pregnant now, but particularly in the woman striving to become pregnant, where we're thinking the cause, it should be removed, whether it's stage 1 or stage 4. So there's no amount of endometriosis that's inconsequential. Any is a lot.
How common is recurrence after a good excision surgery, and how long does it typically take before a repeat surgery is needed?
Yeah, I spoke to that a little bit earlier. I mean, as I mentioned, Dr. Patrick Jung has some pretty good data that it gives you your best shot, or he will say upwards of 85% of people will become pregnant after excision. I struggle to quote that number. It just feels rough to say that number. Because I see the worst of the worst cases. I don't always get to see the easy ones where they're pregnant, they go away happy and live happily ever after. Sometimes they send me an email with a picture of the baby. I really love that, but I lose track, and so it's hard for me to, in my own practice, to see that number. But there is good data that says complete excision, it will never come back. I like to say it gives you your best chance at it never coming back, or it gives you your best chance at the longest interval before it comes back. But I will say it is not uncommon to have to redo surgery. I can think of a patient whose face I can see right now that I did 5 laparoscopies on her for her 3 children. The 3rd child required 2 over the 2 years of trying to achieve that 3rd child. Now, she is by no means common, but that's also not unheard of. So with all things endometriosis, if you think you figured it out, you need to be humbled because you're wrong. But there are some generalities, and in general, complete excision gives you your best chance at the longest interval, maybe that it never comes back.
What do we know about the root causes of endo?
If you use the word know, what do we know? I would say absolutely nothing. It sounds a little cynical, I realize. We think a lot. There's a lot of theories. But the sad reality is very, very little is understood about the origins of the disease. If you look at endometriosis, and in a moment I'll show me excising a piece of tissue that's endometriosis, when I send that to the pathologist and the pathologist looks at it, they will describe the lining of the uterus called the endometrium that lives inside the uterus, even though that wasn't inside the uterus. So it's not exactly correct to say it is the lining, but it is very, very similar to the lining inside the uterus. How that tissue got there, nobody can explain. You might read about so-called retrograde menstruation theories, where there was a theory that menses would go backwards instead of leaving the uterus. It would go back through the fallopian tubes and into the pelvis, and that would seed the pelvis and cause endometriosis. The trouble with that is there are people that have been found to have endometriosis that had their tubes tied before they had endometriosis, so there's no way it could have gotten out. It's been found in premenstrual women at autopsy. It doesn't make sense. It's a very confusing disease, and unfortunately, very, very little is known about it, because through the years, frankly, because of the IVF industry, there's far too little research that's gone into this devastating disease. I can remember in the 80s, yes, the 80s, in medical school, sort of being taught endometriosis is interesting, but don't spend a lot of time on it. It's of historical interest. All of those women are going to have IVF. Well, it turns out that's not true. But even if that were true, it doesn't speak to the devastating pain that some women have to live with because of this disease. I've done a hysterectomy on a 24-year-old before who said, yes, I'd love to be pregnant one day, but I won't make it to that day. I can't live like this. So it's a horrific disease, and sadly, we know very, very little about its true origins. Maybe this is a good time, partly because I'm losing my voice, but maybe we'll go to some of the videos. I think it'll be helpful. Now, trigger warning, this is very graphic, and so if you find this distasteful, look away, but you can't say that I didn't warn you. And so we're going to try my ability to, it seems like my ability worked. How do I freeze right there? Yes, so this is normal pelvic anatomy at laparoscopy. Remember I said I put a camera in the belly button, and this is what I see when I look down into the pelvis. So right is right, left is left. This is a picture of the right ovary, if you can see my pointer, the right fallopian tube, part of it beside the right ovary. There's the right fallopian tube inserting into the uterus. We'll get a little better look at that in a minute. Here's a ligament that attaches the ovary to the uterus. It's called the uterine ovarian ligament, very aptly named. This is the left ovary, a little bit of the left tube. This is a partial view of the uterus and the back side of the uterus. This is the colon, or loops of the colon, and we'll get a better look in a minute, but they dive into the bottom of the pelvis here. So if the woman were standing up, this would be the very bottommost part of the pelvis. This would be the back of the cervix, and then beneath the cervix would be the vagina, obviously, and then below that is where the colon would exit the body as the rectum. So I'll let this roll a little bit forward. Here's a little better view of the fallopian tube on the right side there. And there I'm trying to show this peach-colored tissue here are the very delicate microscopic fingers at the end of the fallopian tube called the fimbriae. Their job is to sweep over the ovary at ovulation and capture the egg and bring it into the tube where the sperm are waiting like little ninjas. Now, the uterus does not move like that naturally, for the record. I have a device inside the uterus, and an assistant at the diagnostic procedure is able to move the uterus around so that I can see. So I don't want you to think that your uterus has motion. It doesn't.
They can't see the pointer, FYI.
Oh, okay, you can't see the pointer. I'm sorry about that. It might be the end here. I think I used it. Yes, I'm using the uterus on the left side there to push up the ovary. In the upper part of the picture, you see the sort of peach-colored tissue. That's the fimbriae, or the very delicate ends of the ovary. And I wish I had a pointer, but on the ovary, which is just beneath the tube, just beneath the fallopian tube, if you look carefully, it has a different look than it does in the rest of the ovary. That's a leftover cyst called the corpus luteum, And that's what's left over from ovulation, probably in the previous cycle. So that's a good review of normal anatomy. Diving over the front of the uterus there or towards the top of your screen is the back of the bladder. And so we'll see some endometriosis there in another video. So that's just normal anatomy. I think the next thing that I'm going to show you is
Same video again, so yeah.
this one. This is an actual patient with actual endometriosis, maybe. Bear with us just a minute. Say you should never do presentations with children or technology. So if you look there, that again, now you're an anatomy expert. This is the uterus. It's got a manipulator in it that's moving. I'm doing a robotic surgery here, adjusting the camera. So if that makes you seasick, I'm sorry. And then if you look, immediately we're going to encounter endometriosis in the bottom of the pelvis when I move the ovary out of the way. And Andrea, if questions come in about the picture, you can stop me and ask me. That's endometriosis right there. I hope you can see it. I'm moving the pointer, but I realize you can't see it. It's in sort of the left side of the screen. In the old textbooks, that was called a gunpowder lesion, as though someone threw gunpowder against the wall and it sort of splattered. But if you look around, there are 3 or 4 of those lesions, and that is what endometriosis looks like in one of its examples. Now, it has a lot of different appearances. That's one of the most common. But there you see endometriosis towards the top of the screen, that dark lesion, then just off to the right in the top of the screen, more endometriosis as well. And then now you're an expert. So you'll see my scissors are right by a lesion of endometriosis there. There's the right ovary, the right fallopian tube. I'll pick that up and look under it because that's a common hiding place for endometriosis. We don't see any under that ovary. But those are really textbook, very, very classic examples of what endometriosis looks like in the pelvis. It's not the only example, but it's a very common example. I think I can fast forward a little bit here, and I'll show you some other stuff. This is excision. I'm going to back that up just a little bit. So this is called wide local excision. We're cutting this out just like you would cut out a skin cancer on the skin. I'm giving it a wide margin so that I'm sure that I'm getting all of the endometriosis tissue out, just like if it were a cancer. And one of the reasons this is so critical is endometriosis lesions are 3-dimensional. They have depth. Sometimes they're very deeply, deeply invasive. And if you try to just burn the surface, it's a tip of the iceberg phenomenon. This doesn't have to be a very deep lesion. We have some deep ones that I'll show you in some of the other videos.
We have some people wondering if you could say like what stage endo this would be.
Oh, this person would be stage 1/2.
And one person's asking, is it normal for the ovary to be so bumpy, for lack of a better word?
Actually, that's a sign of a healthy ovary. A bumpy ovary is a healthy ovary. It sort of looks like, I sort of think of it as the surface of an almond almost. A perfectly smooth, shiny ovary, that's what polycystic ovaries look like because they have all those little bitty follicles in them pushing the surface out and making it shiny and flat when the light hits it. But a normal healthy ovary is lumpy and bumpy. That's just how they look. And here's a little bit of trivia for you. A testicle looks exactly like that, lumpy and bumpy. You can use that on your next trivia. Here I'm going to completely excise this endometriosis lesion, and this is what we mean by excision. This is a very isolated lesion. It's not very complicated for me to remove. You'll see some more complicated ones in just a moment. I'll fast forward a little bit on that. So here you can see the defect that's created after I've excised the disease. I'll let that continue. We're going to come back and close that defect because as that tissue is healing, you can see there's a hole, there's a few holes in view, and then look at the bottom of the screen, you can see the fallopian tubes. Well, because the devil is real, those tubes could find their way to that tissue as it's healing and scar to that open tissue while it's being re-epithelialized, as it's called. So I don't want that to happen. So we do what's called pelvioplasty, and I'm going to sew those back together again. That suture is about the diameter of a human hair. Now, it looks massive here, magnified in the Da Vinci robot, but it's actually very, very delicate. So the goal is to close these defects so the raw edges are not accessible to any other tissue, so there's no scar tissue formation. I often get asked, aren't you worried about causing scar tissue? And the answer is no. If we do the surgery correctly and use the proper pelvioplasty technique, no, we're not worried about scarring. We're preventing scarring by doing that. This step is sadly missed, often by surgeons who call themselves excisional surgeons, and they do actually excise the disease, but they don't take this important step. It's much harder, it's a much more difficult technique, and it probably doubles the time required for the surgery. So it's not always popular to do, but it's absolutely critical in our success for pregnancy. I'm going to fast forward a little bit.
Someone asked if it's possible for excision surgery like this to wake up the disease or make it worse.
No, you're excising it, so there's nothing left to make worse. If we do our job right, we can't make it worse because it's gone. I just wanted you to see there this sort of Frankenstein suture line where that hole was. So now those raw edges are protected, so the tissue doesn't have access to stick there. A common question that I'll get, I just want to show you this. This is not mesh. This looks like mesh. I had a patient call me once when she got her surgery video and was angry because I didn't tell her that I put mesh in. This isn't mesh at all. This is called interseed, and it actually turns to a gel. And you can see it as it gets wet, it begins to turn to a gel, and it becomes sort of a non-stick jelly-like material, almost like spraying non-stick on a skillet. It's just another tool that we have to try to protect anything from sticking to anything else. But what I was going to say is I'm sometimes asked, I don't want you to do endometriosis surgery because I'm afraid you'll cause scarring. And I tend to think in analogies, and my favorite analogy there is you call the fire department and say, my house is on fire. They say, well, be right over. And you say, no, don't. I'm worried about water damage. There's nothing I could do to your pelvis that is worse than endometriosis. But we're going to rid it of the disease. And if we do the surgery properly and do that pelvioplastic technique and some of the other anti-adhesion protocols that we follow, not only are we not going to cause adhesions, we're going to leave the pelvis in a much better place than we found it. So I hope that's helpful. I have a couple of others that we might show if you have additional questions. I show the laser being used and some other techniques, but I can pause for a question or two if that's helpful.
We've got a couple of questions about endo prevention, that kind of thing. She said, in addition to those anti-inflammatory diet ideas that you gave, are there any other lifestyle recommendations for people who have confirmed or removed endometriosis? And someone else asked, are there any cookbooks or anything you know of for an endo diet, or specifically what to cut out?
Yeah, I mean, in reverse order, I think if you Google endometriosis diet, you'll be bombarded with information. And the anti-inflammatory diet, and I think they're essentially the same thing under a different name. Prevention of recurrence is one thing. Prevention of the disease, wow, we don't know what causes this disease, so we certainly don't know how to prevent it. I certainly wish we were in that place. One day, God willing, we will be. But as I mentioned earlier in the broadcast, prevention, complete excision, maybe some dietary and anti-inflammatory lifestyle and dietary changes. Plenty of people would advocate for reducing their toxic load and so-called non-toxic living. There's plenty out there in social media about that. And then one of my favorites, the medication naltrexone or low-dose naltrexone. That's not a lot. It's a lot more than nothing. I wish it were a lot more than that, but that's really sort of the state of the disease where we are today.
Well, we can remind people if they have any last questions to send them in.
Please do.
We can see the laser technique.
Yeah, I'm going to shift then, and we'll go to the laser technique, and we're going to wind down, mostly because of my voice. And let's see here if we can bring you the laser. I often get asked about the use of the laser, and it can be a confusing topic. So it depends on how a laser is used and whether it's a CO2 laser or a different kind of laser. So all lasers are not created equally, and the answer is not the same for every laser. But in our world, in the Napper Technology, Creighton, excisional surgery world, the laser typically is a cutting instrument. So you saw me using shears, little micro shears in the Da Vinci robot. When I was doing that, electric current was going through that in a way that causes it to be a cutting current, not a coagulation or a cautery current, but a cutting current. The laser can also be a cutting tool. Now, the laser can also be a coagulation tool, different wattages, different settings, and different types of lasers, maybe not a CO2, other kinds of lasers. So it's not a one-answer-fits-all things laser. It really depends on how it's being used and how the person is using it. I think we're not going to be able to show it looks like the laser. Is it going to work? Oh, okay. Looks like it will, and I'll fast forward. This is a broadcast that I did for something else, so I'm just going to fast forward that. So this is a really nice example
for pain relief,
these are
increase her recurrence rate,
that have been
and
caused
not
by
help with her
endometriosis in
fertility
this patient.
enhancement and
here,
preservation.
We're using, this is actually my partner doing the surgery, Dr. Jillian Stalling, who's a phenomenal surgeon. And
So again, you can see here that it cuts really very, very nicely. There's really no sort of past pointing, or if there is, it's very, very minimal, and particularly at these low power settings of 4 to 6 watts.
Excise the adhesions.
The power setting that you use and the distance from the tissue is really hard to describe in a protocol sort of way. It's something that you'll just have to experiment with, but it very quickly becomes second nature.
Dr. Stalling is doing here.
Here I'm lysing really right on the surface of the bowel, and you can see there's.
I'm going to fast forward a little. Here she is removing.
This becomes very, very
endometriosis
easy to do
and
with
you
confidence
can see, you
and
can't see
safety.
the laser, you can only see the effects of the laser.
You'll also see a
And
couple
here
of
she's
times,
using it
just
again
like
as a
that,
cutting tool
where
as
I like to use the
dissects the
back
tissue
side
away
of
from
the
diseased
conduit
tissue,
as a blunt dissecting
and,
tool.
removes it
You want to be
completely,
careful not to
excised.
actually touch tissue with the fiber itself.
This
You can
is a
see the
delicate,
fiber extending
maneuver that
beyond the
she's
end there
doing.
just a little bit.
There may be something
Touching
wrong
tissue with
there.
that fiber
There it is.
invariably will damage that fiber, and you'll have to replace
She's
it
actually operating
in the middle of your
millimeters
case.
away from
But
the
using the
ureter,
back side of that
which is
conduit as a
the
blunt
very, very delicate
dissecting
tube that
tool
goes from the kidney
works
to the
very, very
bladder. You
nicely.
can see it moving like a snake-like off to the right side there underneath her instrument. Far too often I'll get a report and it says we removed all the endometriosis, but some of it was over the ureter, so we left it because we didn't want to damage the ureter. Well, I respect that the surgeon did want to damage the ureter, but I don't respect them for saying, I need a surgeon here that knows how to do this when it's around the ureter, like this is being done, because again, it has to be completely excised to be effective. But I think that gives you a nice sense of how the laser is used and as a cutting tool. So don't be confused. Cautery, fulgration, ablation, those are words that you want to stay away from. You want complete excision. And I'm often asked by long-distance patients, if maybe I'm interviewing a surgeon and I want to know, are they an excisional surgeon, how do I go about doing that? First of all, ask them, are you an excisional surgeon? If they stutter, the answer is no. And I don't mean stutter in the speech impediment way. But if they're not comfortable with that question, they're not an excisional surgeon. If they say yes, ask them the last time they did an excisional surgery. If it wasn't yesterday or the day before, I would really question how busy they are. This is something that you need to do, and you need to do a lot, and you need to do it frequently to be good and stay good at it. And then you might ask them, why? Why are you an excisional surgeon? Why don't you just burn it? Because their answer will probably be pretty telling. If you don't get a good feeling on any of those questions, run, don't walk to the nearest exit, get on Google and find an excisional surgeon.
Well, you read this person's mind. One of our last questions, she asked, she has an appointment with the Creighton OBGYN in the next few weeks. Any advice for my consult visit?
That's great. If they have Creighton, if they're a Creighton medical consultant, they are not going to mislead you about excisional surgery. So they either are a Creighton excisional surgeon, or maybe they don't include that as part of their Creighton fertility model work, which is perfectly appropriate and fine. The most important thing about that, if they don't do the complex surgery, they will know exactly who to send you to that does perform those surgeries. So I would say you're off to a really good start.
If you have had excision surgery, how often should you be re-examined?
It depends. So there's a couple of things that will take us back to surgery after excisional surgery. So if we're pursuing pregnancy and pregnancy doesn't occur, at some point, in all likelihood, we're going to find ourselves questioning, is the endometriosis back? So absence of pregnancy, that would take us back. If pain was present, and then it was gone after excisional surgery, like it typically is, and then it returns, that could take us back. And then, of course, a combination of those two things could take us back to surgery as well. So there's no specific time limit. It would be any combination of those could always at least start that conversation of maybe your disease is back, maybe you're a rapid recurrence, as we sometimes describe it.
We had someone ask, what's the difference between endo and adenomyosis?
Yeah, that's a tough word. Adenomyosis, you're very close. Adenomyosis is, well, in the old days when I was young, it was called internal endometriosis, which is actually a more descriptive term. It's essentially endometriosis in the muscle of the uterus itself, not outside the uterus, not inside the uterus, but in the wall, in the muscle itself in the uterus. Very difficult to diagnose. It's not reliably imaged with an MRI or an ultrasound. The only absolute reliable way to know it's there is to take the uterus out, and the pathologist evaluates it under a microscope. But there's certain things that will make us suspect that it's there. Again, it's a form of endometriosis, so if there's traditional endometriosis, we often suspect there may be underlying adenomyosis. It's notorious for causing painful, heavy periods. More heavy periods than probably traditional endometriosis causes. So one of the common scenarios that makes us think that is if we do an excision surgery and the woman's pain is gone, but her heaviness gets worse, it might be adenomyosis as an underlying cause, and that's just one sort of simple example. But common problem, adenomyosis, we're always thinking about it.
Liz asks, what kinds of studies do you know of that are currently going on to study endo? And I might tack on to that after all of these questions that are kind of like, it comes back, it gets worse, you just have to have menopause or a hysterectomy. What is the hope for people who have this disease?
Yeah, I think you can get a sense of hope if you go to that website, Endometriosis Foundation. There's a donate site, a donate opportunity there. There's a list of all the research. This facility is in New York. It's headquartered in New York. There's a lot of people doing good work in endometriosis. Unfortunately, though, just compared to everything else, it's sorely lacking, and that's really because of the IVF industry. In the late 70s, early 80s, everything in fertility just pivoted to IVF. Dr. Thomas Hilgers, the founder of the Creighton fertility model, and some of his colleagues, it was at that point that they said, wait a minute, IVF is not the future. What about all these other causes of infertility like endometriosis? But sadly, they were sort of lone wolves working on this. There's a lot of great people doing a lot of great research now. The part of the problem is, and this can sound a little bit cynical, but there's really no pharmacologic connection to the disease. There's a new blood pressure medicine every other day that comes out on the market. That's because high blood pressure is so prevalent. Every company wants to come up with a blood pressure medicine that's better than the competitors. There's really not a medication or a pharmacologic market, so to speak, for endometriosis, and that creates a bit of a problem when it comes to research. The drug Lupron was the only medication for probably 3 decades. Now there are some newer, potentially better medications coming on the scene that might be good for long-term use and prevention of recurrence, but it's still really early on, and compared to other areas of research, it's really just not investigated. If you ask me what the hope is, I think a better fundamental understanding probably of the immune system component of endometriosis and the inflammatory component. I think increasingly, if we look to our colleagues in functional medicine and in integrative medicine, they talk about inflammation in ways that I'm not capable of understanding as a gynecologist, but it is the enemy of all things human. And most disease processes have at their root, in one way or another, some component of inflammation. So I would imagine in the out years, so to speak, we begin to understand its root causes, its connection to the immune system, its connection to the inflammatory pathways, and find a way to beat it back even better than we do now. I certainly hope so. That's my prayer. Well, you guys have asked some of the greatest endometriosis questions I've ever been asked. I've done conferences with 1,000 people, and people haven't asked me questions that have been nearly as thoughtful. So thank you. I really appreciate you joining us an hour on a Tuesday night for a live event. I'd love to hear some feedback from you about this event. What could we have done better? What could we have presented better? I'd really love to hear from you about other things that you'd like to hear. We talked about polycystic ovarian syndrome today. I was a guest on another podcast today, and we talked for probably half an hour just about polycystic ovarian syndrome. Be happy to do an event like this for polycystic ovarian syndrome. If you like this kind of content and you'd like to have more access to this type of one-on-one content, I'd love to hear from you. We'll be reaching out to you electronically with opportunities to do this and some other pretty exciting things, I think, having to do with all things women's health, not just endometriosis, but certainly more on this devastating condition. So thanks to our friends at the Holy Family Birth Center who made and produced and owned this studio and let us use it to produce content like this. Thanks to my producer, Andrea Soretti, who answered the questions or asked the questions and kept me going so well as she's done for many, many years. Thanks again for joining us. I really appreciate it. I'm Dr. Chris Stroud, and we'll be back again soon with more live Q&A on all things women's health.